Thanks for listening to The Spark, Medical Education for Curious Minds, where we bring you the latest ideas and insights from faculty, students, and staff in UCSF's medical education community. I'm Megan O'Connor, Instructional Designer with the Technology Enhanced Education Group.
And I'm Karen Fleming, Communications Manager for the Office of Medical Education. This month's episode is devoted to Breast Cancer Awareness Month. We talked to second-year medical student April Liang about her research project on breast mammography data and her goal to help improve breast cancer screening. April's work is part of the Explore track of the Bridges Curriculum Inquiry Program, and her work with mentors Dr. Dexter Hadley and Dr. Hari Trivedi. We also interviewed Dr. Hope Rugo, a UCSF medical oncologist and hematologist, who directs the UCSF Breast Oncology Clinical Trials Program. Dr. Rugo gives perspectives on the latest advances in breast cancer research and patient care at UCSF. Let's go to the interview with April. So April, can you tell me a little bit more about the goals of your project and why study this area or particular aspect of breast cancer research?
Sure. So the ultimate goal of our project is really to improve breast cancer screening. So as you may know, there's lots of confusion right now around different recommendations from different medical societies on when women should start getting mammograms and how frequently. And part of that controversy is really because mammograms are imperfect and therefore can lead to harm. So, for example, of 1,000 women screened by mammography, about only 5 to 8 will have cancer, but 100 of those women will actually be recalled for further workup, which means more mammograms and potentially even a biopsy. So that creates a lot of anxiety and distress for patients, and not to mention, you can imagine a huge healthcare cost burden every year. And another interesting issue with mammography is that since we've started looking for breast cancer, we have been able to find more cases of it. But what's interesting is that we haven't actually been able to reduce the number of deaths due to breast cancer. And that suggests that we are finding kind of breast cancers that are so slow growing that they probably never would have progressed to something that the woman would have noticed or, bothered the patient. So the goal of the project is really to improve mammography by making it more accurate and also giving it the power potentially to predict which findings will become really, really aggressive and should be treated right away.
And what sparked your interest in this research area?
Before starting medical school, I actually took a gap year, and I had the fortune of working at the UCSF Breast Care Center with Dr. Laura Esserman, and that experience really taught me a lot about breast cancer, the controversy around screening mammography, and what it's like to be a patient going through all of that. So since then, breast cancer research has been something I was interested in. And in college, I also studied computer science. So it's always been a goal of mine to combine that background of mine with something in medicine. So I did some searching and found out about Dr. Hadley's lab on this project to do with mammography and machine learning all in one. And I was like, that's perfect. So that's how I got into this project.
Can you tell us more? What does big data mean, and what's the relationship to precision oncology?
To me, big data is basically just a massive amount of data. And I think what's really interesting is that as a field, medicine has been generating a huge amount of data and continues to do that already. But most of the time, that data is just sitting in the electronic health record and not really helping to advance our knowledge as a field. So for example, specifically around mammograms, since I'm working in that, the San Francisco Mammography Registry was an effort started at UCSF over a decade ago, and in that time it's collected kind of mammography data and outcomes data on over 450,000 women, 2 million mammograms, and 30,000 breast cancers. But on the flip side, it's also been a project that's been years in the making, and millions of dollars have been spent, trying to make that effort, to realize that effort. And in terms of precision oncology, the relationship is that once we have that data aggregated, we can combine lots of patients' information on biochemical markers, family history, genetic information, X-ray images, any other imaging data, and we can combine these and analyze them, and that could allow us to identify new cancer subtypes or disease markers. For example, we might find a patient with one characteristic genetic finding that makes them particularly susceptible to a type of chemotherapy. So really, I really believe that big data that is well curated, combined with the power to query that data for meaningful new knowledge, is really the foundation for precision oncology.
You talked a little about the difficulty of utilizing big data in research. How are you addressing those challenges in your project?
Yeah, so as I mentioned earlier, large curated and structured data sets are pretty hard to come by in the medical field right now because of how much they cost and how long it takes to kind of create those data sets. So almost everything is in kind of free text format, and what's very frustrating is that often we need to kind of wade through sentences and sentences just to find one key result. So in our study, one thing that we're really using is pathology reports from patients who underwent mammography and something was suspicious. So when something is suspicious, sometimes these patients are asked to get a biopsy where a sample of that suspicious area is taken out and a pathologist is asked to look at those cells under the microscope. And when pathologists do that, they write a very detailed narrative report on their findings, often with a conclusion on whether the suspicious mass was benign or cancerous. And the details are really great, but sometimes in the case of our research, we really just need to know, was the suspicious area benign or cancerous? So as part of our work, we're trying to train computers to read these pathology reports for us and classify the result as being benign or cancerous. We've polled about 3,900 pathology reports from the UCSF database, and we asked if IBM Watson, which has gotten a lot of press recently, if IBM Watson could do this classification just as effectively as these more traditional but technically and time-intensive methods. And what's really exciting is that our preliminary results show that IBM Watson does just as well as those traditional methods, if not better, at this task of reading pathology reports and kind of drawing out that conclusion. So the plan for us is to use IBM Watson eventually to automate the labeling of all 33,000 path reports that we have sitting on our database and associate those results with the mammograms as a ground truth labeling.
What is the potential of using knowledge from big data to study breast cancer and the possible implications for patient care or treatment?
With the kind of population level data that we'll be able to access and analyze in the study, we really have the power to change how mammography is done and breast cancer screening is done. We could really enhance mammography to make it more patient-friendly in the sense that it can still catch the cancers early, but we can avoid doing a lot of the unnecessary biopsies and unnecessary recall for those patients who were absolutely sure, this finding isn't something that represents cancer.
Now that we've heard from medical student April Liang about her inquiry project in breast cancer research, let's hear from Dr. Hope Rugo.
So, Dr. Rugo, we've seen tremendous progress in breast cancer research and patient care over the 15 years. What do you believe are the most promising discoveries and advances?
15 years now is a fairly long time in breast cancer research and actually dates back to when we first had data showing that HER2-targeted therapy for a subset of breast cancers that have gene amplification in ERBB2 or HER2 could actually dramatically improve survival in patients with early-stage HER2-positive breast cancer. That discovery actually, which unfolded over a number of decades, led to a whole new appreciation to the use of targeted therapies, and in looking at subsets of breast cancer and now many other cancers for specific markers, genetic or protein markers, that would suggest responses to specific therapies. The whole story behind HER2-positive breast cancer is quite fascinating, but that is really one of the very exciting models of advance in cancer therapy, because it went from being the worst subset of breast cancer with a terrible outcome to being among the best, because we have this new therapy. And of course, it became a huge area of research as everybody tried to create new targeted therapies for HER2-positive breast cancer. Then subsequently, the most common subset of breast cancer are cancers that express hormone receptors. And for a long time, we've known that hormone therapy can work if you block the receptor or block production of estrogen, but that cancers develop resistance and either recur or grow again in the metastatic setting. We now have a couple of targeted agents that are approved to add to hormone therapy for metastatic breast cancer that have had really dramatic impact on the length of time that the disease is controlled. And in general, we've been able to overcome some of the toxicities of these therapies and make them quite tolerable. And now over 15,000 women in the next few years will be enrolled in early stage trials with these targeted agents added to hormone therapy in an attempt to prevent recurrence of higher risk disease. So that's a very, very exciting new area. And then lastly, I think an area which has been made a big splash across cancer and less so in breast cancer is immunotherapy, trying to enhance the host's immune response to cancer. And the reason why it's less big in breast cancer is because breast cancer hasn't been considered very immunogenic. But we've actually discovered now that there are ways to combine immunotherapy with chemotherapy or other immune agonist type therapies to enhance the effect. And then in some of the subsets of worse breast cancer, if you treat earlier, it's better than later. You would think that as the cancer grows that you would get more inflammation, but actually as the cancer grows and gets increased mutational load, it actually becomes more immunologically cold. So we're learning a lot about giving these immunotherapies earlier in the course of disease. And of course, with all of these new therapies, now we have to learn how to use them in the smartest way possible for those who really need them.
Despite advances in treatment, though, including the advent of targeted and refined treatment approaches, some aggressive breast cancers and those that are triple negative remain difficult to treat. What opportunities can better diagnostic approaches potentially offer and/or combination therapies?
Well, this is a really important area, and just to speak to your question, it's not even just the most aggressive cancers. We understand now, even more in the last year, that even our slower growing cancers, that there's differences between these different cancers where some of them still have a recurrence risk out to 20 years and others you could potentially not treat or not treat much and they would be fine at 20 years. I think that what we're really focusing on now is trying to ask the cancers more about their genomics and their protein changes when they first appear to try and more effectively target those cancers.
What has surprised you most in your own research recently?
I think that there are several things that have surprised me. One has been the relationship between toxicity and response for immunotherapy, trying to meld what we have observed in and studied in the treatment of breast cancer, which with what we're beginning to understand about the host immune response. And then I think one area that's kind of, I guess, sobering in a way is that we have a lot of new treatments. So our patients are living longer with metastatic incurable breast cancer now than ever before. And what we're seeing is that we're seeing the cancers develop resistance markers as we're treating them. And we're seeing more cancers that start out as hormone receptor positive that lose those receptors over the pressure of treatment. Fascinating. And really, of course, it brings us back to the idea that we want to treat them in the best way in the beginning, because if as you're treating, the cancer keeps finding ways to escape. And then lastly, I think the collaboration, one of the kind of really exciting areas has been collaboration with patient-reported outcomes and supportive care and palliative care. That's been kind of a surprising thing, that we can help patients to live longer and live better by providing them multidisciplinary support, not just with breast medical oncology and surgery when needed, as well as our radiation oncology colleagues, but also with our development of the advanced breast cancer program with Mike Rabo in symptom management services, where we actually have a support system for patients who have metastatic disease that starts right away when they're diagnosed. And then lastly, we started more than a decade ago looking at trying to prevent hair loss in patients who are getting chemotherapy, primarily for early stage breast cancer, where you might get 4 doses of chemo and have no hair for took 6 to 12 months to recover. And so we started this scalp cooling really because a patient brought up to me that she was desperate not to lose her hair. We had some philanthropic funding again. And what's evolved over the last 10 years has been really fun and exciting. We now have an international collaboration looking at scalp cooling and how to best improve scalp cooling. We have 2 FDA-cleared devices in the United States. And all of that started here at UCSF with our multidisciplinary program.
What has most inspired you recently in your interactions with patients?
You know, my patients really inspire me on a daily basis. And it's always hard to think about what most inspires you because the patients are such amazing people in general with almost always this tremendous internal strength and excitement. The patients who are so interested in clinical trials, participating in clinical trials for them is a passion, something they really want to move forward with to try and push the treatment for cancer forward. Our patients who are so involved in supportive care. I had one young woman who worked in the lymphedema network and worked just tirelessly, even as she was dying of cancer in her early 30s, to help other people, to provide a resource for patients with metastatic breast cancer, to help lymphedema, to fundraise for me through t-shirts. Still working on that up until the day before she died, where she was saying, but I want to make sure the art for the website is right, and I want to take care of this and that, where these people give really all of themselves to try and make sure that the world they leave behind, they've made a mark on and made it a better place.
I can easily see how UCSF physicians, such as Dr. Rugo, through her dedication and innovation in improving care for breast cancer patients, would inspire medical students here to consider a career in oncology and to pursue research projects in this area. Thanks to the UCSF community of faculty, residents, and learners who work so hard here to improve well-being for people living with breast cancer.
We hope you're subscribing to The Spark on SoundCloud. Stay tuned for our next episode, which will include a special interview with the School of Medicine Dean, Dr. Talmadge King. The music in this podcast comes from Poddington Bears Egress, licensed under CC by NC 3.0 and available at thefreemusicarchive.org.